Good morning. Thank you, AIOS, for the opportunity. My one point to make is to never hesitate when you are loading the lens, when no matter which lens you are loading. This is a case where we were implanting a trifocal IOL, and as you can see, as the lens goes in, it goes in without the trailing haptic. Often, when we are loading these lenses, not much thought is put because we do not think about the parent biomaterial of the lens. We should always remember the parent biomaterial of the lens is very important in the lens quality and character, even if the further modifications of the lens are so to speak multifocal, etc. You can see that this case is especially important because it went in without a leading haptic as well as a trailing haptic. So both the leading haptic as well as the trailing haptic got stuck in the injector, that's right, when injecting this IOL. And so the IOL was taken out, cut, and then a fresh trifocal IOL was put in the back. So we usually think that the trailing haptic is probably a mistake that our assistants do or we do while going in, but sometimes even the leading haptic can break. So it just went in as a single optic inside the eye. Thank you.
Thank you, sir. Any question? Now I would like to Dr. Lipi Mittal.
OT10. So good morning everyone. Thank you AIOS for this opportunity. Voice.
Slightly, some are present, some are.
Shining metallic fragment into missing. Sometimes the smallest missing fragment becomes the biggest post-op nightmare. Remember, vigilance saves vision. This was a routine phacoemulsification which was performed using a blunt chopper where I noticed a floating shining metallic fragment into the anterior chamber. So identification is the first step which is important to prevent complications like PCR and DMD. Stop and coat the endothelium and posterior capsule with dispersive OVD. The fragment was grasped using a microforceps and it was removed safely under direct visualization, and the surgery was completed uneventfully. It's important to identify the intraoperative instrument breakage. Remember, repeated sterilization can cause structural weakening. If you're a beginner, contact with vibrating phaco or excessive force during surgical maneuvers can lead to intraoperative breakage. Timely replacement of the instruments and inspection of all instruments before surgery is very important.
Thank you. Thank you.
सर नेक्स्ट स्पीकर जो हैं वो ताशरी नुपुर
डॉक्टर नुपुर गोयल.
उसके बाद ताशरी
बुला लो, इसको बुला लो.
नुपुर गोयल.
A routine case of sac syringing in a patient with epiphyseal came for preoperative clearance for cataract surgery. So after injecting the fluid, we expected either the syringing to be patent or regurgitation. So as you can see the diagram 2, whenever the fluid is injected in the sac, either it goes down to the nasolacrimal duct and the patient feels in the throat, or if there's a blockage, there's a regurgitation from one of the punctum. But in our case, something else happened. So as the fluid is injected, patient is asked if she can feel the fluid in the throat, and she says no. So, what is the mystery of this vanishing fluid? So, we repeated Roplas after the sac syringing, and there was regurgitation of the fluid from the punctum. So, hence, the mystery was solved that we were dealing with an atonic sac. So, atonic sac is where the sac loses its tonicity to pump the lacrimal fluid outside the nasolacrimal duct. Since it's a lacrimal fluid stasis, it's a potential source of endophthalmitis and needs treatment DCR surgery. So, the take home message is repeat Roplas after sac syringing, and awareness about atonic sac is important. Thank you.
Thank you, ma'am. Next speaker is Dr. Hitashri HR. I think it is on that.
Himanshu, ask him to play again this one. Huh?
So this was a case of SICS by a postgraduate where this bad big brick kind of a nucleus was dropped into the vitreous cavity, and post vitrectomy the fragmatome stopped working, and so we went ahead to use this needle technique where the hardest part of the nucleus was poked and the nucleus was lifted up, and as we already had a quite big SICS tunnel, the nucleus was easily delivered through the SICS tunnel. This is to just say that we need to just adapt at the situation and go ahead and finish the surgery. And the results, the patient is doing good with good 6/9 vision.
So this was post vitrectomy.
Yes, yes.
Next is Dr. Nilesh Kumar.
Mike, Himanshu, call the next.
Thank you, Ayaz, for this opportunity. So I'm today going to talk. The one tip that I am going to give is that in MIGS sometimes the tilt that we always feel is not required. The only thing that we need to know is that there is a 60-degree offset that we need to create from the patient's head to our eye, and that is the only thing that needs to be there. So this will help in the resource limited area, like where the microscope is not as good, and you don't have a tiltable head microscope in peripheries. You can still do MIGS. It's not like you can't do it. So it is like you tilt the patient head towards the opposite side, and you can do it with the instrument going into the diverse position. So let's see the surgery that is there. So you see immediately I'm not tilting the microscope. Only the patient head has been tilted, and we just move in the y direction and make the patient lie down. Put visco gel. This is a cohesive viscoelastic that is there, and I use not the Vogue one, but a disposable eye prism SX, which is available with the care group, which is for the eye stent. I use that gonio prism, and you just go inside that. The only thing is that the instrument position will be completely perpendicular, so you have to be very sure that you are entering with entering in the proper plane and not early to that. and you can see, sorry. So this is a tornado hook that is manufactured by Georgia. So with that you can just go and sweep it across. With the perpendicular, it's very easy. The ergonomic is very easy to maneuver inside the plane, and with that you can complete the SICS without actually having a tiltable microscope. Thank you for that.
Dr. Karan Bhatia's video, please.
Uh, 43. 43. So Dr. Karan Bhatia sir is not present because of some family emergency, so I'm just going to play his video. This is a case of an ICL. Yeah. So ICL that with high volt has created a glaucoma risk because of rotation that was done for a young female medical student. She underwent both eyes ICL, and you can see with the high volt and the rotation there was chafing that was there. So once you rotated that thing and created a PI, the volt reduced, and with that volt the IOP came down. So the message that he wanted to give with this is sometimes secondary glaucoma can develop with ICL if the volt sizing or the ICL sizing is not proper, and that can happen with some students as well. So this was non-resolving even after the rotation, and then he had to actually explant and counsel the patient that let's be with the glasses, be glaucoma free. So sometimes you have to actually take out and don't be that the ICL has to be there and we will keep doing something. When in doubt, just explant and reevaluate with that.
Thank you, sir. And next speaker is Dr. Satanya Saha. She's there. Actually, you are Neil Kavadia. Okay. It's not writing.
Good morning, everyone. Today I present a deceptive case. A young male mechanic presented with sudden painless vision loss, floaters and mild redness, fundoscopy revealed retinal detachment with retinal folds and a dense white cystic lesion, confidently masquerading as an ocular cysticercosis. But the real twist came in the operating room. The patient was taken up for a pars plana vitrectomy, and after core vitrectomy, there it was. Not a parasite, but a well-encapsulated intraocular foreign body hiding in plain sight. After carefully dissecting the foreign body out, a sclerotomy incision was performed, and using intraocular foreign body forceps, the culprit was finally extracted and taken out from the eye. There it is. After suturing the sclerotomy incisions, the subretinal fluid was drained, endolaser applied, and C3F8 gas tamponade sealed the finale. Post-operatively, the retina remained detached, the vision improved gradually. A forgotten trivial 4-year-old injury finally confessed its role. This case highlights in ophthalmology, ghosts do exist. Thank you.
Okay, thank you, Doc. Next speaker is Dr. Sangeet Mittal.
Audio, please.
You don't decide how your story begins, but you do get to decide how it ends.
63 years, female presented with 2 PC IOLs, one in AC and other in vitreous. Partial thickness scleral flaps were made horizontally. First PC IOL was removed from anterior chamber. Posteriorly dislocated IOL was separated from vitreous adhesions. Vitrectomy was completed. IOL was lifted using active suction and removed through scleral tunnel. Flanges were fashioned with 5-0-proline by piercing the haptics of the C-flex hydrophilic IOL. Using a 26-gauge needle, the opposite end of the suture was externalized at the desired fixation point beneath the flap. Flanges were then created at both ends under the flap, and the flaps were secured with fibrin glue. Just don't goof up IOL placement. Never implant 2 IOLs or a PC IOL in AC.
Thank
you. Next speaker is Dr. P. Ravi Kumar.
Meanwhile, can we have the next presenter, Dr. Kamaljeet? मैम को वो शीट दे दे जो राकेश सर
I shall be discussing the role of 25 gauge 1-inch long needles. It can be used in bimanual dissection in cases of proliferative diabetic retinopathy with combined RD. In this case, the membrane is lifted from the disc with the help of forceps, and all the attachments of the membrane from the underlying retina, they can be removed with the help of a needle. This step has to be done very carefully as it can cause retinal breaks. This needle is attached to the aspirating tubing so that the heme can be aspirated at the same time and the surgical plane becomes clearer. So the take-home message is it is an effective tool in bimanual dissection in PDR with combined RD cases, and it is an effective tool in the armamentarium of a VR surgeon. Thank you.
Dr. Neil Kavedia.
So we speak about Oguchi disease, the color-changing fundus with the beautiful Mizuno Akumura phenomenon, having a prevalence of barely 500 cases worldwide. So this is a young female that comes to us with night blindness, and now you'll see how beautifully, just in a cost-effective way, using a 20D lens and a smartphone, the red color of the fundus will change its reflectivity into a golden yellow metallic sheen. Now, the reason this is important is because this is a type of stationary night blindness, and you don't want to mistake this in the form of any kind of dynamic degenerative retinal disorder and give unnecessary anxiety and stress to the patient, because the vision is going to be preserved over time. And similarly, we as doctors, so this is the normal red fundus glow, and on exposure to light, you can see how beautifully the golden glow is formed. And we as doctors should also remember this, because we have to issue medical certificates. So before issuing any kind of false medical certificate, this is important. The reason I'm presenting here is because this is for the first time we've documented this in the form of fundus videography rather than static fundus photographs. Thank you so much.
Dr. Anahita Shroff is here. Is she there? Okay. Shouldn't
OPT 6.
Good morning, everyone. My one point is going to be it's not over till it's over. So this was a seemingly smooth cataract case with a clean bag and IOL in the bag. And while I was forming the AC, it had formed quite decently, but I have this OCD of having a tight chamber, and I was confident about my tunnel. So I just thought if I hydrate it enough, it has to form. And so I kept hydrating it. So now this is where I should have stopped and taken a suture at the side port. But no, I thought if I just hydrate a bit more, it is going to form. And that's when the unthinkable happened. So when I was hydrating it, suddenly the IOL disappeared and the anterior chamber was filled with vitreous. And I was clueless, and I think the IOL had dropped. You can see right now that the IOL is here, and in a millisecond, the IOL is not there. But after slow motion, we realized that the IOL had in fact been expulsed out, which was so fast that we could not see it intra-op. So it is not over until it is over. You should know when to stop and never overhydrate the AC, especially with a wide bore cannula. Sorry?
Done.
Thank you.
Dr. P. Ravi Kumar.
My presentation is not a simple technique, pneumoimplantation of IOL. So in cataract volume surgeries, the techniques can be performed in both SSAs and phaco. The advantage is prevent the wound leakage, inflow of surface fluid, endothelial cell loss during vigorous visco wash, and seals DM detachment while using the manipulation of the wound site. Air bubbles safer to the endothelium and also avoids tasks that may occur but left out viscoelastics. So let me show this video. And the air bubble. This is PMA lens is implanted. The wound construction perfect, easily simply goes. Foldable IOLs. In phaco also you can do it. If wound construction is perfect, you can easily go through. And in the minutes the surgery will go finish off. No need to visco wash and all. You have the post-op, the crystal clear cornea you can deliver. Thank you.
Thank you, sir. Next speaker is Dr. Bala Saraswati. She's there. Dr. Bala Saraswati. Okay. Can we have Dr. Ashutosh Kumar Gupta?
Three zero. In next 1 minute, I am going to talk about the management of large macular hole. In case of large macular hole, according to close study, if we do ILM peel, the success rate decreases from 96 to around 80 to 90%. So ILM flap, and that works very well. And in this case, the size was roughly around 1200 micron. So a multiple ILM flap was done. The residual ILM peel was ILM was removed, and there was a type-on closure. Another technique we can do, we can do the macular hole massage. Here I have used modified soft tip cannula to massage the macular hole.
I think you also have one more video to show.
32, please. Dropped 70-year-old male, history of trauma, and there was dropped across type IOL bag. So with the 90 prolene, it was fixed. The advantage of this because there was no corneal incision made, and then it was fixed with a 90 prolene. The sutures are attached by the scleral canal partial technique, so they get buried once the case is over. So post-op there is no exposed suture and corneal incision. Thank you.
Next speaker is Dr. Shruti Malkapuram.
34.
Which is a benign self-limiting disorder of early childhood characterized by triad of nystagmus, which is high frequency, low amplitude, and head nodding and torticollis. It typically appears between 4 to 18 months of age. Case presentation: a 2-year-old child presented with rapid shimmering eye movements noticed by parents. There is intermittent head nodding and abnormal head posture. There is chin uplift. There is no history of trauma or systemic illness. There is normal developmental milestones. On clinical examination, the visual acuity is central, steady, and maintained. The nystagmus is of high frequency, low amplitude, and asymmetric. Head nodding is intermittent vertical movements. There is no strabismus. The anterior and posterior segment examination of eye is normal, fundus examination is normal, and cycloplegic refraction is done. The normal ophthalmic and neurological examination supports its benign form. On clinical triad of nystagmus, head nodding, and torticollis, the diagnosis of spasmus nutans is made and this is presented for its rarity.
Dr. Sugato Paul.
I'll demonstrate a new technique if Brian Little's technique doesn't work. Here, the Rexis has run out. I have noticed that and stopped immediately, gone in and put viscously over the run out area in the periphery to flatten that area. Then with a Haldipurkar forceps, tried a sharp pull in the center, but it didn't work. It stays in the periphery and I couldn't pull it back. So I'll be demonstrating with the Johnson's bar how I could retrieve the Rexis. So with the Johnson's bar, I'm pressing just beyond the limbus to relax the zonus so that the pull of the anterior capsule is gone, and then very easily I could retrieve the Rexis back. Here I'm demonstrating another case where the Rexis has run out again. So once the visco is put inside the anterior chamber where the Rexis has run out, I have pressed the limbus with the Johnson's bar, as you can see, and you can see how easily the Rexis is retrieved back because the zonus are relaxed by the. Thank you.
Thank you, sir. Next is Dr. Vijaya Sau. Meanwhile, can we have next speaker, Dr. Kavita Ramakrishnan? Dr. Kavita Ramakrishnan. Dr. Siddhartha Ghosh.
Thank you, AIOS, for this opportunity.
This video describes a unique sign that is seen when the capsular tension ring is implanted in the bag. The capsular hook supporting the bag snaps out of the bag spontaneously as soon as the CTR is implanted. This I call the capsular hook snap sign, which confirms the correct placement of the CTR in the bag.
Sometimes it happens that we have placed the CTR, but we are not sure if it has gone in. This is a sure shot sign. If the capsular hook comes out spontaneously, the CTR has gone into the bag and it has stretched the equator, and that's why the hooks will come out. I call it the capsular hook snap sign. Thank you.
Dr. Vijay Shah.
So good morning everyone.
One point I to make is that the prophylactic vitrectomy can prevent the preventable in ARN cases. So here I am showing a case, young patient with presented with a complaint of pain, redness, or watering for last 4 months, and it was suspected case of ARN. So patient was started on the Belgan cyclovir and vitrectomy was planned, and media was very hazy due to cataract as well as vitritis. So the first vitreous biopsy was taken for the PCR, and and gradually there was a very easy PVD induction was there in the particular this case, and vitrectomy was done to trim the vitreous over the ARN margins, and the laser 5 to 6 rows of laser was done around the all retinitis cases, and the case was closed under the oil. So you can see the peripheral, there is a retinitis in all 360-degree areas, and the laser was done on 4 to 5 rows and all around the retinitis area, and oil silicone oil was injected, and after 2 months oil was removed and cataract was done. The patient was doing well with 636 vision, and the PCR was positive for HSV plus Epstein Barr virus. Thank you.
Dr. Parinish Ravi. Dr. Chaitanya Ankam. Dr. Chaitanya.
This is a posterior polar cataract handling. Predict, protect, and preserve. Rupturing PC is a pressure and vector program. Early detection gives predictive results. If you have available of IOL Master or 700 IOL Master ASOCT, you can use them to detect it. There are intact signs, aperture, and bumpy bulging. And control rexis, no hydro dissection, and gentle endonucleus mobilization, central debulking, and preserve epinuclear cushion. Make sure the tip sleeve and fluidics must match, and straight tip has better maneuverability. Video. Okay, the video is not playing.
Can we have the
Okay.
next speaker then?
Meanwhile, we can have other speakers. Dr. Sefali Shahu. Shahu. Dr. Shayana Bumla. Dr. Shayana Bumla.
A stitch in time saves 9. Let's see how. This is a patient showing positive Siegel's test post trabeculectomy. You can see the aqueous leaking from the edge of the flap. This aqueous leaking from the edge of the flap leads to hypotony, causing a massive serous CD. The serous choroidal detachment is so massive it's reaching till the posterior pole. However, if you take a simple bleb-forming suture where you anchor the conjunctiva to the cornea, you can prevent this complication. And in this particular patient, once this bleb-forming suture was put, the CD was resolved. That's why we say a stitch in time saves 9.
Thank you. Dr. Kovagapu Sujanya Kumari.
A stuck trailing haptic will be stressful during the phacoemulsification. So there is a safe rescue maneuver in which external cartilage decompression can be done by 15-degree Parker plate. Trailing haptic got stuck during IOL insertion. So external cartilage decompression is done with 15-degree Parker plate away from the main port incision. So which relieves the haptic preventing the further IOL exchange and tissue damage complications. Thank you.
Dr. Shreya Bhatt. And meanwhile, next speaker should be ready, Dr. Mithun Tulsidas.
A 14-year-old female presented following a snake bite where the pediatrician noticed anisocoria, raising suspicion of neurotoxic envenomation. General physical examination was within normal limits. Coming to ocular examination, right eye was within normal limits. In the left eye, pupil was 7 mm dilated. Direct reflex was not reactive to light. However, indirect reflex, left eye did not constrict on shining light over the right eye. Near reflex was normal, pointing away from acute neurotoxin effect. Hence, further pupil evaluation was done in bright light and dark, where anisocoria was noted to be greater in bright light. Dilute pilocarpine test with 0.125% pilocarpine was done, where the affected pupil constricted significantly after about 40 minutes, confirming cholinergic denervation hypersensitivity, classic for AD tonic pupil. She had no ocular or systemic neurotoxic signs and neurological evaluation was normal. Thus, the anisocoria was unrelated to the snake bite. An incidental diagnosis of left eye AD tonic pupil was made. The take-off message is this case emphasizes that although it is important to rule out dangerous signs of neurotoxicity in eye following snake bite, not every abnormal pupil after snake bite is due to venom, and hence a careful neuro-ophthalmic examination is crucial to avoid misdiagnosis and unnecessary intervention. Thank you.
Dr. Mithun. Next speaker will be Dr. Joan Sarkar.
History included prior glaucoma surgery and medications. Systemic history revealed nephrotic syndrome. Initial examination showed poor vision, elevated IOP. Cornea showed microcystic edema with bullae in the right eye. Left eye fundus was normal. Systemic examination revealed characteristic nail pitting. Clinical profile suggested nail patella syndrome. RD implant placed in the ciliary sulcus. Post-operative, vision improved, IOP controlled. Significant improvement observed post-operatively. Nail patella syndrome, rare autosomal dominant disorder. Ophthalmological involvement mainly includes glaucoma. Early recognition and multidisciplinary care are crucial. Look for systemic features, especially in young patients with glaucoma.
So the take-home message will be to look for systemic features, especially in patients with young glaucoma, and the importance of surgical timely intervention so that you can save the vision as well as save the life of the patient. Thank you.
Dr. Jones Sarkar.
Can I have my presentation, please? A very good afternoon to all of you. Can I have my presentation, please? OPAD 84. OPAD 84, serial number 26. This is an edited video of impending expulsive hemorrhage. We have done something innovative to prevent expulsive hemorrhage during the penetrating keratoplasty. So please enjoy the video. OPAD 84. 82.
I will be presenting piggyback corneal grafting, a novel technique to prevent impending expulsive hemorrhage. Flaring a ring applied 2 side ports made AC formed with cohesive viscoelastic. Then partial trephination done, corneal button started to cut, but high positive pressure noted with forward bulging of iris IOL diaphragm. Immediately stop cutting and a suture was placed at 9 o'clock position. AC reformed with cohesive OVD, already cut graft anchored with 10-0 suture at 6 o'clock position. Other end of graft suture passed and graft was fallen back like LASIK flap, endothelium coated with dispersive OVD. Immediately switched on to host bed and 9 o'clock suture cut, already anchored graft fallen back on opened globe and sutures done fastest. Thus salvage the globe from impending expulsive hemorrhage. Complete the surgery uneventfully.
Thank you very much. Thank you.
Dr. Chaitanya Engam.
In PPC is a pressure vector problem. Early detection gives predictive results. You can use IOL Master or AS OCT if it's available. Controlled X6, no hydrodissection, gentle endonucleus mobilization, central debulking first, and preserve epinucleation. Make sure tip, sleeve, and fluidics are matching, and peristaltic is little more forgiving. Straight tips have a better maneuverability.
Can we have the next presenter? Dr. Sneha?
Ensure there is no pressure differences, and keep your parameters low, and just do the hydrodissection in the right plane, hydrodelineation in the right plane, and then mobilize manually. And then once the endonucleus is separated, you could do the fake emulsification, and low AFR and low vacuums, power is also minimal. Bottle height 80 to 90 should be sufficient. And with a straight tip, you can just turn around so for easy maneuverability without coming out and in multiple times.
Dr. Sneha Chakra.
Good morning all, and thank you AIOC and AIOS. Today we'll talk about the story of an 11-year-old who had come to me on her third consecutive visit for angry red looking eye with mass growing over both the eyes. She had been suspected of OSSN and underwent biopsy for the same earlier, but on examination there was progressive mass along with giant papillae. On eversion of lid, immediate treatment of injection steroid with maintenance of drops were given, and the results were dramatic. The right eye and the left eye showed regressing mass over 2 weeks, along with the papillae in smalling of size. 1 month with maintenance of drops, followed by second month, and the 2-month follow-up showed more or less complete regression of the mass. Thus, knowing that bilateral mass with typical signs and symptoms should be taken care of VKC first rather than being OSSN. Thank you.
Dr. John Davis Akara. Dr. John is here. Anyone left? Done.
Hello. Thank you for the wonderful case presentations. We can wind up for this session now. Thank you.